Welcome, everyone, and thanks for joining us this morning for our monthly breakfast series. Today, we're discussing innovating to advance health equity. It's through our monthly breakfast series program where we tackle big subjects. Our member meetups and community conversations allow us to dive into topics in more depth and highlight proven models of work. And we're always accepting ideas and feedback on our program, so please reach out if you have any questions or suggestions. We do have some new attendees in the room, so I want to remind you that Social Responsibility Chicago has a strict no solicitation policy. We're here to attend today's program and learn from each other, so please respect this space. Questions can be submitted into the chat, which we will direct to our moderator throughout the session. Also, I'm Brandon. I'm the president of Social Responsibility Chicago, and when I'm not working with a Social Responsibility Chicago, I'm the vice president of brand engagement for the YMCA Metro Chicago. If you're not a member yet with Social Responsibility Chicago, I encourage you to sign up. It's through our membership we're able to produce dynamic programming and share valuable thought leadership resources on timely topics. We're always enhancing our members-only offerings, delivering even greater value to you and what you bring to your work and your organizations every day. Membership info will be shared in the chat and can be found at srchicago.org. I want to extend my gratitude to our Social Responsibility Chicago members and the contributors who help shape our programs, and today's program is no exception. I'm going to go a little bit in reverse order and introduce our panelists first, and then our moderator, and turn it over to her. So starting first, I would like to introduce and have her give just a very quick opening. Dr. Allison Arwady, the Commissioner of the Chicago Department of Public Health. If you could give us a quick introduction, that would be terrific.
Yeah, thanks, Brandon. And thanks for having me. I appreciate everybody joining. I am the commissioner at the Chicago Department of Public Health. You all know me as COVID, the COVID doctor for these last few years. But in fact, at the health department, we, of course, focus on a range of issues. Very briefly on health equity. In early 2020, the COVID pandemic was not the only thing the health department was focused on. We also released our 5-year plan called Healthy Chicago 2025. It is explicitly focused on health and racial equity. It focuses on the 5 main drivers of the racial life expectancy gap in Chicago, which is now over 10 years difference life expectancy between, for example, white and Black Chicagoans. That got worse during COVID. Those 5 main drivers, in case you're curious, the biggest one, more than half, is chronic diseases still. Diabetes, heart disease, asthma, followed by gun-related homicide, followed by infant mortality, followed by HIV and other infectious diseases, which of course now includes COVID, and that knocked it up into the second. And then finally, opioid overdose. And so those are the main things that my department focuses on while we work to try to keep all of Chicago, of course, protected even outside a pandemic. Thanks.
Amazing. And I can't wait to get into it in just a second here. I want to introduce our second panelist, LaRon Taylor, Director of the Blue Door Neighborhood Centers, Blue Cross and Blue Shield of Illinois. LaRon, if you could give us a quick intro as well.
Good morning, everyone. LaRon Taylor, Director of the Blue Door Neighborhood Centers, where our mission is to make a positive impact on the health of the community by increasing health equity and health literature overall, health knowledge. We have 5 focus areas: behavioral health, diabetes, heart disease, nutrition, parent and child wellness. And of course, we work with over 150 community-based partners to bring social determinants of health resources and assistance. And I should definitely say that the Blue Door Neighborhood Center is brought to the community by Blue Cross and Blue Shield of Illinois. You do not have to be a member of Blue Cross and Blue Shield to participate in our programs and services. And of course, all of our programs and services are absolutely free. We have 3 locations across Chicago, 2 on the south side and 1 on the west side. And you can find out more information about the Blue Door Neighborhood Center at www.bluedoorcenteril.com. Thanks for having me. I look forward to our discussion today.
Terrific. And love the work you all are doing at the Blue Door Neighborhood Center. It's just wonderful. And our last panelist, before I turn it over to our moderator, is Dr. Garth Walker, Senior Medical Director of Value-Based Care at Rush Health. Dr. Walker, could I give you an intro?
Sure, Brandon. Thank you so much for having me, and thank you everyone for allowing me to share the space with these wonderful human beings. My name is Dr. Garth Walker. I serve as the Senior Medical Director of Value-Based Care at Rush Health, where I help lead value-based strategy for our health system. Prior to this, I served as a White House Fellow. I worked for the Surgeon General, helping advise on several of his advisory reports from healthcare worker burnout to youth mental health, and then also interface with HHS around a lot of their health equity strategy. Before that, I was Deputy Director of Illinois Department of Public Health. So many of you may remember me talking incessantly about getting vaccinated and also trying to build trust in our communities. Thank you for having me, and I look forward to this discussion.
Thank you so much. And so now it's my pleasure to welcome today's program moderator, Anna Lee, Vice President of Initiatives and Public Programming for United Way of Metro Chicago. Anna, I'll turn it over to you. Invite our panelists to come back on camera, and you all take it away. And you're on mute, Anna.
Apologies. Good morning, everyone. My name is Anna Lee, and I'm the Vice President at United Way here at Metro Chicago. And I'm so delighted, number one, just to be invited to have this conversation with this brilliant group of panelists. I want to thank you all for some grace this morning. Clearly, we're not used to commuting into the office, and I hit some traffic. Actually, United Way's internet is down. So I'm calling in through my phone, but all is good. We're able to make this happen. You know, as I was reflecting and just preparing for this conversation, I thought a lot about what public health is. And thankfully, so many of the panelists, especially Dr. Walker and Dr. Arwady, have taught me so much about what public health is. And it really is, you know, our ability to navigate our world, to know that we have hope and access to possibilities and opportunities. You know, even this morning, I made coffee with tap water. I walked out the door and I had different options to get to work. I probably should have taken the L instead of driving. And, you know, I realized, and I had a home that was safe. I didn't have the threat of violence on my body. I had, you know, I opened my refrigerator and I had access to good food with fresh produce. I didn't have that. I'm just a coffee person usually. But, you know, it just made me think that that's health, that's wellness, right? And that allows me, like all of those social determinants of health, provide me a platform in order to be healthy. And even as we were thinking about the kind of conversation we wanted to have, we knew that these past few years, COVID has really uncovered the inequities here in Chicago. I live in West Ridge, which is 60659, and place matters, right? My zip code matters to my actual health and well-being. And here in Chicago, while it is a world-class thriving community, we know that segregation has made it that we have populations, especially if you're Black or Latinx, that your health outcomes really may be determined by where you live. And COVID has really uncovered that, right? It really kind of stripped away where we see the segregation, where we see the disparities in health. And I think I don't know if Brandon talked a little bit about this, but you know, we know that there are discrepancies in not only health disparities, but even life expectancy. And if you live in the Gold Coast, or if you live in Englewood, there is a 30-year lifespan difference, which is astounding, right, for a world-class city like Chicago. So with all of that, we thought we would have a conversation with these experts to talk a little bit about what they have seen these past few years and, you know, where we need to go when it comes to the health of our city and public health here in Chicago. So let me first start with Dr. Arwady. You know, the pandemic has really highlighted these longstanding disparities in health within our communities. Could you talk a little bit about what you learned during the COVID-19 pandemic and, you know, the critical needs to address those social determinants of health? Why don't we start with Dr. Arwady, and then I would invite Dr. Walker and Laurent to add anything to what you say.
Yeah, absolutely. And yeah, thanks for setting that up. A lot of people still don't realize that health departments like the Chicago Department of Public Health, we may provide a little bit of direct medical care to fill in the gaps, but much more of our work is actually about these underlying root causes of health. And so, COVID, as everybody on this call is well aware, upended almost everything in our lives. And in so doing, I think it really held up a mirror to society. And it said, where are the cracks? Where are we failing? Not just in health and in health access, but where are we failing as a society and who are we failing? And so when I think about here in Chicago, as COVID started to emerge, all of us who work in the space of health inequities, we know these maps of Chicago that will look slightly different depending on the disease or depending on the risk factor. But we know the communities of vulnerability, partly because we do have such a history of racial segregation and disinvestment over decades in these communities, that as COVID started to merge, no big surprise in terms of where we were seeing that earliest disease spread. But an infectious disease, I think, gave us an opportunity as a society to think a little bit differently about what those risk factors are, because it felt new and different. So for example, food insecurity. We've always worried about food insecurity as a city, but in this case, if you were food insecure, it meant you couldn't stock up for 2 weeks or a month on your groceries or get them delivered to your home. You were needing to be out and interacting more. You're needing to make sure that, we're filling in those gaps in terms of where you're getting resources, where folks lost jobs, et cetera. But it also literally meant you're having more interactions. The term essential worker and how that came to mean something very different, I find really interesting, because it wasn't, again, just about sort of healthcare workers, although of course, our amazing healthcare workers across Chicago were stepping up and really being at a lot of acute risk. But it was about folks who were doing all of the in-person work again, that didn't have the ability to work from home once we figured that out. We think about internet access. Whole swaths of Chicago had very limited internet access, where you look at that by zip code and how were we getting information? How were you getting, the things that folks needed during the pandemic? And so I think it opened up this conversation about social inequities and social determinants of health in a way that made everybody recognize our interconnectivity. Because of course, when any part of Chicago is unhealthy, that is a problem for us all, but you hear it more with infectious diseases. I also think, just to sort of finish up, and I want to hear what the other panelists have to think, it offered us a real opportunity to say, let's try to put approaches that have health equity at the center. Let's actually try to put those into action. So right away, within the first couple of weeks of those crazy days back in March, the mayor said, we're standing up a racial equity rapid response team. How often do you think about racial equity and rapid response together? In my opinion, almost never. But it was about, what are we going to do to actually work to try to build some trust where, for very good reasons, little exists, to put extra resources where it's needed, to listen to communities, set these tables. And that focus really became, throughout the whole pandemic, I think, an opportunity for us to try, as a health department and as a city, to do things that aren't just talking about health equity, but really trying to make a difference. Probably the biggest was when vaccine first became available. Y'all will probably remember that Beanie Baby phase, when it was very hard to get a vaccine. And, first healthcare workers, there were a few groups that were first eligible, but we made a decision here in Chicago, when the CDC was still saying you needed to be over 65, there were these particular limits. We chose some zip codes, some neighborhoods that were absolutely driving our pandemic here. They were also the ones that had the most gaps in terms of economic security, food insecurity, et cetera, but also they're driving the most infection. So it's best for the city to get those resources in to the root of where the infection is. And so we prioritize for everybody age 18 and up in those zip codes at a time when everybody else had to be 65 or one of those groups. It's very hard, because it means saying no to communities that are used to always being put first. But it was an example, I think, and an important example for us of trying to put this into action, doing something that's harder, not just equality, but actual equity.
Thanks so much for that, Dr. Arwady. And if I just, whenever I have the opportunity, I want to thank you for, the way that you served our city during those early weeks, those early days, and really having the courage to center equity in all of the practices. And you are such a leader, and that you think about opportunities, even now, in kind of closing those disparities, and thinking about it not as like, oh, this is exhausting and I'm burnt out, but to think about like opportunities to further advance equity and closing those disparities it's just really inspiring. So thanks. I invite Laurent and Dr. Walker, if there's anything that you wanted to add there.
Yes, certainly. I totally agree with everything Dr. Arwady just spoke to. One of our approaches at the Blue Door Neighborhood Center from the very beginning, back in 2019 when we opened our doors, was to really focus on areas that were vulnerable. And our approach was to use data from Chicago's Hardship Index to determine where the most vulnerability around the city is, right? Also recognizing our presence and our partnership with many of the community-based organizations, nonprofit organizations that are doing the work, in that very important work in Chicago. So when it comes to the COVID-19 pandemic, we were in many of the areas that were hit the very hardest, right? What we saw was a limelight, if you will, on those racial inequities, specifically health inequities. And so we quickly responded by double downing on the partnerships that we had to keep many of the organizations that are mission driven doing that work open through sponsorship. Secondly, by improving our trust in the community by leveraging experts internally here at Blue Cross and Blue Shield of Illinois, like our Chief Medical Officer, Dr. Robinson, to have discussion with the community around the importance of COVID-19 vaccination. Then we quickly responded by partnering with FQHCs as well as the city to provide vaccination clinics. And from a social determinants of health perspective, we also saw and knew that the impact of COVID-19 on food insecurity was immense. And so with that being said, we partnered with the local food produce supplier, T. Castro, to provide directly to the community fresh produce that could be used to supplement some of the meals that our community was preparing. So quickly responding, quickly educating the community around COVID-19, and of course, double downing on our partnerships through sponsorship as well as volunteerism. Many of our employees here at Blue Cross and Blue Shield, as well as at the center, at the Blue Door Neighborhood Center, quickly responded by providing PPE directly to the community. And then what we also learned as far as accessibility, that our programming had to change. And so we quickly pivoted to offer virtual programming and connect individuals and families who had issues or challenges with internet accessibility to organizations that could assist with that. Because we know that that is something that prevented many individuals, vulnerable communities and families from accessing the health education and resources that they needed at such a dire time.
Thanks so much for sharing all of that. I just appreciate, number one, how everyone had to pivot, mostly because so many of our grassroots organizations were pivoting to meet the needs of our residents. And we're going to pick up on some of those themes that you mentioned about partnership and also, deepening trust in our communities in order to address the public health crisis, but then also moving beyond and thinking about other health inequities. Dr. Walker, did you want to add anything?
Sure, Anna. I think I'm probably the only only person that probably has had 3 different jobs over the past couple of years during the pandemic. And I think one of the most interesting things that I've observed from different vantage points, whether it be an academic, at the local level, federal level, and now at the health system level, the common thread is just leaders having to rethink the different touch points in terms of how we think about our health. You articulated very clearly about how much of what you do in your day-to-day life reflects in your ability to live a healthy life. And I think at the height of the pandemic, in terms of disparities from the academic standpoint, no one was surprised by who was to be most affected. I think there was a lot of literature out there that everybody could reference in terms of who would be most vulnerable. But what we did have to do was be able to leverage that information and be able to act immediately. And then also think about how we sustain that long term. So oftentimes at the state level, when we were thinking about different public health strategies, we had to think about public health strategies that could not only last to be 5-10 years, but also be repurposed for different public health crises that have been affected by a lot of these drivers historically in Chicago, when we talk about racism and wealth gaps, et cetera. And then also just in terms of access, and how do we make sure that different public health frameworks can exist for a long term and be repivoted for issues that may not necessarily just be related to COVID, but perhaps violence, or perhaps food deserts across Chicago. So those were just some of the findings that I think were interesting, but a lot of common threads across different vantage points that I think everybody's trying to tussle and understand how do we best leverage our position to be part of the solution.
I'm so grateful for all this wisdom this morning. And well, first, I'm so grateful, while it probably was a bit chaotic to have 3 different jobs during this time, that you were bringing your perspective and your expertise in all of your roles, and we're all better for it. And I also love that idea that as we were addressing these immediate needs and pivoting, recognizing that this was an opportunity to think about more long-term, impacts. And we'll go back to that theme too. And that actually leads to the next question, just about kind of beyond the pandemic response. What are some of the shared values and community impact of advancing health equity? I'd love to start with Laurent in you answering that question.
Sure.
Really build the point that you made already about building trust and, leveraging existing coalitions.
Yes, definitely. Building trust is imperative, and we're still at the Blue Door Neighborhood Center. We're still working on that every day. And so how we improve our trust and credibility is by being very poignant and specific about the partnerships that we engage in and we collaborate on. And with over 150 partners, one of the things that we all share is we all put the community first. In addition to that, we utilize listening sessions and surveys to hear directly from the community what they need and what they're looking for from Blue Cross and Blue Shield of Illinois, but specifically from the Blue Door Neighborhood Center. And so I'm happy to share with you all today that using that formula, if you will, we've had over 37,000 visitors to the Blue Door Neighborhood Center since 2019. And that includes members and non-members, right? So our community trust, our relationship with the community is imperative. And of course, as I mentioned earlier in my introduction, our 5 focus areas, right? We go beyond those 5 focus areas. I've heard so far since we started this discussion around violence prevention and intervention, recognizing the impact of violence, all sorts of violence, not just gun violence, but domestic violence, bullying. We have taken an approach of providing prevention for different age groups and the family as a whole, right? And so we're working with our community partners to improve education, awareness, and resources around behavioral health, violence prevention. And one of the strategies that we also use is making sure that our programming is extremely engaging. And so we have a great team here at the Blue Door Neighborhood Center. They're extremely innovative, and the programming that we are able to provide directly to the community is engaging, and the community responds positively. Hence that figure of 37,000 participants here at the Blue Door Neighborhood Center.
That's astounding. 37,000. I'd love to hear Dr. Arwady and Dr. Walker, if there's anything that you wanted to add with regards to, moving beyond the pandemic and thinking about these shared values as we close health equity, the disparity.
Yeah, I mean, it's such a huge question. And, listening to Laron there, it was just making me think a little bit about how at the health department, we've really tried to take some of the, I think, structures that have served us well during COVID, particularly this, what does it mean to create a network across providers, if we're back in the health system, for example. And so, whereas prior to COVID, the health department operated a few mental health clinics, for example, that wasn't meeting the needs. It wasn't really particularly equity driven. We knew there's a lot of folks even now in Chicago who are unable to access behavioral health care because we still have this separation between physical health care and behavioral health care, like too often. That instead, taking those lessons from COVID, we created what are called trauma-informed centers of care, and we're funding hundreds now of organizations that are providing high quality mental health care. In return, they are providing it to anybody in Chicago, regardless of their income, their insurance status, their ability to pay. It lets us be much more nimble in terms of where there are trusted providers, whether those are federally qualified health centers, the behavioral, the mental health centers funded by the state, whether those are things the county is doing, whether those are even food pantries who want to embed social workers and counselors into the work that they are doing. It's about not waiting for people to come into the healthcare system, but bringing this access to health to communities. We're now putting providers into the libraries to be able to do, counseling there. And so it's been this way of saying, let's be less rigid, let's meet people where they are, and let's be honest that the same model of an approach to healthcare even isn't going to work for every community. And we've got to help build the trusted providers that already exist, especially in the neighborhoods where the need is greatest.
Yeah, I mean, I think we've all seen that trust and how we access care will be different based on who you are and based on where you live, and that we need to build that broad infrastructure in order to meet those needs. It's great. Dr. Walker.
Sure, I'll be quick. I agree with everything that was said, and I think there's no doubt that community-based organizations were so critical and so needed during the pandemic. And I think it invited different ways for people to view how we include them as part of our health system, not even from just in terms of a traditional community service, but also as part of a health system in terms that could potentially be involved in healthcare delivery. And I think when we think about trusted members in terms of who we partner with, when I was at the state, one of the things that we tried to make sure was that whoever we partnered with had some form of experience, history with the community that we were talking to, that we were aligned and that we were being a trusted partner in terms of how we wanted to make sure that we communicated, that we were coming from the appropriate space, and recognizing that every community that we may talk to may not be along the same journey in terms of trying to get vaccinated. And then understanding that model was effective in terms of trying to get more people vaccinated, rethinking about how we repurpose that for other issues. And I think that those models have been such great models in terms of serving as an example to try to communicate complex information in partnership with somebody that knows the community,
Mhm.
that it will be here to stay in terms of how we think about understanding the lived experiences of the communities that we serve.
Mhm. Thank you. If I may, I wanted to pivot a little bit, and actually we did touch a bit about this in talking about how we all had to make adjustments and pivot. And I would imagine like the reason for that is because of data and like the information that we were sharing. And I would love to just hear about how we all used or harnessed data, and technology to understand where we needed to focus and also to measure outcomes. And, in an effort to scale health equity efforts. So maybe we can just start with you, Dr. Walker, about, how you saw the role of technology and how you use data to kind of make those necessary pivots.
Thanks, Anna. So the way I leverage data today is a little bit different than how I was looking at it 2 years ago. I think at the height of the pandemic, public health really got pushed to the front. When you think about priorities, nobody necessarily tried to put public health at the forefront until COVID-19, obviously. And by using the public health approach, leveraging data to help make decisions, it's an effective model that can be frankly used in almost any environment.
Mhm.
Here, as Senior Medical Director of Value-Based Care, what our focus is trying to develop different reimbursement models. And when I say that, traditionally, we are traditionally incentivized by fee for service, meaning physicians are typically, health systems typically compensated by volume. And sometimes that incentive alignment is not necessarily perfect for trying to deliver care the way that we want to. And what value-based care does is try to focus on quality and cost reduction and outcomes. And since the pandemic, health systems have transitioned from what we used to call the triple aim, quality, cost reduction, population health, to also adding health equity as part of that strategy for health systems.
Mhm.
With respect to data and analytics, analytics is a core component of value-based care. You have to be able to observe populations to be able to have good analytics in terms of whether people are getting screened, where
Mhm.
people live, what are some of the resources accessible. All that paints a picture in us being able to understand what to do. But I
Mhm.
also want to talk about different analytics that may be derived from algorithms, and algorithms can be biased. And
Mhm.
as a health system that's operating in a space that has a health equity strategy, and we see ourselves as being part of that solution to reduce the life expectancy from the west side to the Gold Coast, we have to be able to stress test those analytics and make sure we're taking a fine-tooth comb to make
Mhm.
sure that the interventions that we're putting forth is not widening disparities. And I think that is what we need to be able to challenge our institutions to do, is that we're very disciplined in terms of evaluating the analytics that we put forth to make sure that we don't have unintended consequences, and also check people that may have ulterior motives and may have that may be more intended consequences. But I would say that that is one of the most important things that we do as leaders, is making sure that we look closely at how we leverage the analytics and where it's coming from.
Yeah, I mean, even just like, being very clear about how you define success and, what is exactly that we're measuring. And then making sure that it is intersectional, as you talked about, like quality and equity, like those things go hand in hand. And cost savings too, right? We know that if we do close disparities in equity and racial equity, that it will, like, we will all be better off. So that's great. Dr. Arwady, did you want to add anything to the just talking about data? And
Sure.
it's funny because I think about, whenever we have a surge in numbers, I'm still looking at the data dashboards that are available on the website. And so
Yeah, sure. So
yeah.
right, chi.gov/COVID- is still up and going strong. But it's interesting because, public health has historically actually always been pretty data driven. We have lots of epidemiologists whose entire job it is to look at the data of populations to make recommendations to evaluate, our responsibility is everybody who lives in Chicago. And so we've always had this internal data focus, but I think COVID, to this point, we used to be happy when we'd get, 10,000, 20,000 hits on a data dashboard. And then with COVID, millions of Chicagoans coming, and it made us think really differently about how to turn this data into data that showed me my neighborhood, my subgroup, my race, ethnicity, my age, like how to have that data that we historically think at a population level, actually a lot of work into turning this into something that means something sort of at a neighborhood level, and also bringing that data to these neighborhood tables like week after week after week and using it to make a decision about where are you going to stand up a testing site, what are you going to do. Right, again, COVID was moving fast, and so there was a chance, I think, to show how you can actually use data to very quickly, especially for government, very quickly pivot. Does it work? Is it not? How do we change? And that approach, I feel so strongly, is the right approach, whether you're working on violence intervention, whether you're working on mental health, whether you're working on infant mortality. The reason we choose life expectancy as our North Star data point here at the health department is because you cannot fudge that number, right? There's a lot of numbers that you can say, oh, this is getting better for this subgroup. Life expectancy, to me, is about how we are doing as a society. Very few people would argue that life expectancy, higher life expectancy, is not a good, and it is not something that should be available to everybody who lives in Chicago or in the US. And so taking health is a general good that people believe in, and then turning that into very concrete actions based on data that a company can use to say, with my own employees, what's something I can change? What kind of impact does that mean on health? Like, that's measurable. And I think COVID set us up well to actually do more of that as a society.
Yeah, and that's so helpful. When I think about being transparent and providing all of the rich data that you have and your department has. And we've talked about this, I know, in conversations about that public health. It is, you can't fudge the numbers. It is what it is. And, we recognize that in this moment in history, a lot of public health principles and best practices have been politicized. And there is some, I want to say, narratives that are not based in facts and driven by the data and how dangerous that can be. So
you can debate all you want what we should do about a problem, but we better have some basic agreement about what the problem is, what that data is. And that's the part that I feel is sort of our primary job often as a health department. Let's have some agreement about what is the issue that we're seeing. And then we debate and sort of try different interventions and work to test them and see if we're making a difference on this. But I think too often in this country, we got those two things mixed up, as opposed to what do we do about an issue? It was about, is there actually an issue? And that becomes, I think, potentially quite dangerous, where we can't have some basic trust in the underlying data, even if there's going to be debates about interventions.
Well, I'm so glad you're so clear on that. Laurent, wanted to include you in this conversation about using data and technology.
Sure. It became even more important to Dr. Arwadi's statements previously that we leverage our data that we have here internally, not just the data that's provided by institutions like CDPH, but also the data that we have internally here at Blue Cross and Blue Shield to really determine the specific need at the neighborhood level, at the zip code level. And we were able to do that. And although we have 3 different locations at the Blue Door Neighborhood Center, we were able to really cater, if you will, our programming to the specific needs of the neighborhoods that we serve directly using data that we have internally on our members. Secondly, going back to social determinants of health, we were also able to leverage not only assessments, but platforms that are used to track those social determinants of health needs, right? And actually close the loop on many of the referrals that we are continuously making to our social service, nonprofit, community-based organization partners, right? And so that became even more important during COVID, when we were actually able to track from beginning to end a referral around housing, a referral around food insecurity. And what we saw that is not only did we have direct impact on health literacy and knowledge, right? But we had direct impact on those tangible needs that the community and our visitors were expressing to us directly. So I totally agree on the importance of using data, but also using data to provide tangible results, which also help to increase our credibility here at the Blue Door Neighborhood Center, because what that did for our visitors specifically, it said, this is a hub, this is a place that I can go to receive assistance, and this is a place where I can go to receive assistance, but we're going to track that need, we're going to track that referral and that assistance provided. And when I have other challenges, I can go back to the Blue Door Neighborhood Center. When I have a need for health knowledge and health education, I can go back to the Blue Door Neighborhood Center. When I have a need for low impact fitness, and we all know that fitness is extremely important. At least I know that, as I gained weight during COVID. But either way, we know that the Blue Door Neighborhood Center is a central location that the community can leverage with assistance and to provide direct, tangible results to the community.
I so appreciate what you were talking about too, about providers asking those questions about the social determinants of health and how it, has direct impacts to one's health. In my recent checkup with the doctor, they were asking questions about violence, access to food, and not because I trust my doctor and that they ask those questions. I mean, I just feel like the checkup is a whole different quality too. So I feel like the quality of care is even better. So it's just so encouraging to hear that that's becoming a regular practice for you all. It's great. I want to ask a question. So much about this group this morning with the Social Responsibility Chicago and also United Way. And I think for many of your organizations, we know that we can go farther and go deeper and be more sustained in the work that we do if we do it together, right? And that our approaches are working across sectors. I would love to hear from the panelists, what you think are important or, key things to think about as we partner across sectors in advancing health equity. We can, I would love to hear from all of you, and maybe Dr. Walker, you can begin.
Sure. No, I think public-private partnerships are very critical. One of the programs that we just got incorporated into was ACO Reach, a partnership with CVS. At CMS, they try to test different reimbursement models. One of them is called ACO Reach, which specifically focuses on health equity, and it requires participants to put forth a health equity framework. And in this case, different ACO models are judged by who is included in that model, by area deprivation index, kind of analogous to a social vulnerability index, which reflects the challenges that people may have by where they live within the region. The reason why that's also important is because it did allow us to systematize SDOH screening, the same SDOH screening that you probably went through in terms of asking about housing, violence, food insecurity, and the like. And the importance of that is that it does allow us, and it does increase our likelihood to be able to share data, partner with state and federal institutions to be able to identify gaps within our city that are frankly just not allowing our patients to be more healthy. So for example, if we see at zip code 60652 where there is food insecurity, people don't feel safe walking in the neighborhood, we can take that information, we can go to Dr. Arwady or the mayor or the governor and be like, hey, we really see this as an issue. How can we partner to be part of the solution? And then in 2016, that predates me, leaders that are still here, Dr. David Ansel and Dr. Lateef, really made health equity as a strategy of our health system framework. And I think that goes in line with the mission of us trying to be part of the solution in terms of trying to close those gaps. And I think when we look at institutions, whether it's an academic institution, federal institution, or private institution, we all see that we are very strong stakeholders in public health. And we have to be able to ask ourselves, what are we doing to be part of that solution? And that's sharing data, and then also sharing in the thought process in terms of trying to put forth interventions to close those gaps.
Yeah, I mean, in order to really engage in authentic partnerships, there is that kind of looking in and internal and, thinking about how we are transparent about our own practices as we apply and, look to others to partner and think about like what others bring to the table. Dr. Arwady, Laurent, do you have other things that you'd like to share just about cross-sector partnerships and how, we need them to leverage them in order to close those disparities in health?
Yeah, not everybody realizes, but Healthy Chicago 2025, which is our 5-year community health improvement plan, that is actually not just the health department's plan. That is the plan of the city of Chicago put together with all like hundreds of different partners, private employers, healthcare partners, folks who work on a whole range of public health issues. Separately, the health department does some strategic planning, but every 5 years, this community health improvement plan that we do, the next one will be in 2025, is this focus as a city to say there's a million things we could all be working on. But at least here in Chicago, we are all going to make some commitments, and there's very specific roles that all of these different folks can play, and people can look at the plan to see more examples of this, to work on the racial life expectancy gap. And so whether that is employers thinking differently about their hiring practices, we've seen some amazing examples of that in the healthcare sector. People really saying, I want to hire from the zip codes that I am serving. I'm going to think differently about what perhaps my educational requirements, can I do and earn as I learn? How am I going to think really honestly about sick pay and family leave and some of these basic things that turn out to have a pretty significant impact? How are we as a city going to make sure that people are getting a living wage, they have access to insurance? And so in each of these areas, as whether a particular organization is focused on violence or focused on infant mortality or focused on opioid overdose or focused on education or the other broader things that help make us kind of healthy as a society, that is public health, sort of whether people realize it or not. And
Yep.
I do think one of the major pluses here in Chicago has been the way we saw people step up, organizations of all sizes from across the city say, how can I do things a little differently in the name of promoting public health? And if we can keep that energy going, we can keep improving these other long-standing inequities that have been there and that we are starting to make some progress on. So I would just encourage people, I totally agree with the data focus, but be part of the planning with the health department. On our next round, check out Healthy Chicago 2025, check out the Health Atlas, and then be part of our planning in the next 5-year cycle as we think about being serious about promoting public health and health equity in Chicago.
And thank you so much for lifting up the plan. It is a robust document that is, has some bold, transformative goals, and we absolutely cannot attain them, meet or exceed them without everyone contributing, and that's going to take all people. During COVID, I think we saw public health workers, expand and recognize that we all have a role. So thanks for that. I see that we are running low on time, and we didn't get through all of our questions. And really, these conversations are best when we are able to engage those who are listening to ask their questions. And because I'm going through my phone Megan or Mary, like, do you want to just ask the questions? I don't want to mess up my look through the chat and lose you all. So I don't know if someone wants to go off mute and just ask the questions of our panelists.
Sure. Hi, I'm Megan Lynch. I'm a member of the Social Responsibility Board of Directors, so delighted to have this conversation. One of the questions that came up directly for Laurent is about the platform used for the referrals that you discussed. That came up twice, if you want to address it.
Sure. So one of the platforms used that I spoke to leveraging local data, neighborhood data as an internal tool, but referring to the referral, the closed loop referrals, then that was Healthify. So here at the Blue Door Neighborhood Center, we utilize Healthify. All of our staff here, our health educators, our concierge here are trained to use Healthify. As a matter of fact, I should also mention our outreach team. So in addition to the teams that are located at our 3 Blue Door Neighborhood Centers here in Chicago, we have a robust, great outreach team that really service the entire state, right? And so that outreach team is also trained to operate Healthify, to also provide referrals as they perform outreach around the state to different communities that they serve.
Great. Maybe we have time for one more question before we wrap up. I don't even know. Let's see.
Great. This is a question for Dr. Arwady. And the question is, do you imagine bringing the trauma-informed centers of care concept to other areas beyond mental health?
Jen.
So the trauma-informed centers of care is what we are, specifically calling the work of the city across behavioral health. So that's mental health and kind of substance use. We certainly have a lot of violence prevention work that ties into our mental health and substance use work. But I think more broadly, it's this idea of making sure, kind of off the last question that, we were just hearing about, how do you have these referral loops? How do we all actually know what each other are doing? That has been a little bit of a gap, I think, sometimes here in Chicago. And so, I know, United Way, very heavy in the new 211, for example, if somebody wants to talk about that, but that's brand new here in Chicago. We've been the only large city in the US that hasn't had a single phone number that you could call to get health and human services help. And we have it now, right? And that's the kind of thing that it doesn't always sound that sexy, but the work of making sure that we can help people navigate, and we're creating a framework that allows, amazing organizations like Blue Door, that the folks who live there, they can come in, they know where it is, but it's like, if I'm not connected to that one and I need something else. So a lot of the work of a health department, similar to the trauma-informed centers of care, is actually about that, working to kind of stitch together a little bit of a network and stitch together the resources that people have available and make it easier for people to connect. So 211, which is a city and county and United Way and many, many, many partners involved, and it's been open for a month, is, I think, an amazing example of the kinds of structural things we need to do here as a city. And so with trauma-informed centers of care, I'm very data-driven. We went from serving about 3,600 Chicagoans to over 70,000 just in 3 years with that increase. And we're doing a lot that's needed. There's a lot more to go. But I think in all of the areas that whether that's the newborn home visiting program, we want every baby born in Chicago to have the ability to have an at-home nurse home visit a couple weeks after birth. We know that helps with outcomes for both the mother and the baby. Like, in each of the broad areas of focus, we have a similar, how do we think of this as a system? How do we pull partners together? But I think they're not different to me in the mind, even if they might have slightly different names, and they're all part of Healthy Chicago 2025.
Terrific. Yeah, I mean, I just think about, I appreciate what you're saying about, how we build that connection, those connections, just because for so many years, we're seeing that many of the neighborhoods are disconnected. I'm going to pass it. I feel like this conversation could go on. I am so grateful to our panelists. I learned so much today, but also just, you know, as I mentioned, in the months and years before, you all have just been champions of public health and well-being of our city, and so grateful for the work that you do. I'll pass it back. Do I pass it back to Brandon or?
Actually, that would be me,
Oh.
Kate Narden. Hi, everybody. My name is Kate Narden. I'm the VP of Programs for SR Chicago. And I just, on behalf of all of us and our member community, I really want to thank you, Anna, and for all of our panelists today for sharing your expertise, your passion, your commitment to the city. This has been a really inspiring way to start off the morning. So again, thank you for your time. To our attendees, I hope you learned something new about how we can all help to promote public health and move the needle on outcomes here in our city. Social Responsibility Chicago will provide a curated summary of today's conversation, so please look for that. We'll post it to our LinkedIn and our other social channels. And for our members, I would just like to invite you to March 21st. Please save that date. We will be having our next in-person breakfast program at the Harris Theater. And we will be focused on arts and culture and their impact on our city. If you're not a member of SR Chicago, I encourage you to head to our website or LinkedIn page, reach out to any of our board members or Mary to learn more. Once again, thank you all for starting your day with us. I know I'm inspired and interested to learn more, and thank you again. Have a great day.